15-minute presentation of different projects, projects or initiatives or clinics that are existing across the country. So if you're interested in being a presenter for just 15 minutes, we'd love to hear from you and get you to present at the top of the next meetings. Okay, so I'm going to talk to you a little bit about On Track. We actually were around 14 years ago, and it was at that time called TRAC 2. It was called Taking Responsibility for Adult Care. Now it's Transitioning Responsibly. This time we're back, and it's a province-wide, multifaceted project because of the scope of our funds, and as I get into it, you'll see it's not a program and it's not a clinic, which means it doesn't have a we're hoping to work it to become very sustainable and embedded into people's practices, but it isn't a freestanding clinic or program on its own. Our overarching goals are to support comprehensive, continuous, accessible, sustainable care. Our target group for sure is our youth with chronic health conditions and or disabilities that are 12 to 24 years of age, and of course their families. We're looking at not only the transfer, but also the planning and the preparation. We're looking at transfer out of children's and firm attachment to primary care and adult specialist services. And you can see we've got a big team here. So we've got nursing, medicine, evaluators, researchers, quality assurance leads, and then we have specific project leads. We are very lucky to have a youth engagement facilitator who is making sure that we have youth voice at every table. And we're really lacking is at this time is a family voice that's paid for. So these are basically our collaboration and funding partners. I said it was provincial. The project started in 2011, and it will wind up by 2015, but like I said, hoping to be very sustainable. BC Children's Hospital is sponsoring clinical practice guidelines, which is a lot of what we're kind of about with this CASC project. Also, BCMA, BC Medical Association, has really funded us in a lot of ways, and it's really to make sure that we have the role of the primary care physician or nurse practitioner as part of the transition process, and also the specialist services just to look at long-term care plans. And I'll go into those a little bit later. The Vancouver Foundation has provided us with funding for Youth Voice, and what's missing is family for sure. And helping us guide the project provincially is Child Health BC, our University of British Columbia for research, and same with CFRI. I think what's important this time around is evaluation is key and core to everything we're doing. We're using a triple aim approach and improve. I can go into those, but basically it's best practice for the best experience for youth and families for the best use of our dollars. Okay, so if we break it down really quickly into the domains, you have all of those projects that are happening, but we have basically 3 core domains that we're focusing on. So clinical developmental guidelines is looking at core recommendations that we're going to be working on later, as well for our whole CASC project. We're standard templates for preparation and transfer. I'm going to go into some of these for you, and the long-term care plans. Our community engagement is youth and families, and it's so important to have a respectful, valuable, really ensuring that they're at the table in all the work that we're doing. We have 2 youth advisory committees, actually, one in hospital and one that's starting provincial, that is directing what we do. We are engaging more and more with condition-specific groups like diabetes and I think spina bifida, certain community groups out there, as well as kids' youth camps. We're looking at developing online resources so people that are more isolated in the province for sure can access it, and we know that's where the kids connect to, is online. We're also looking at mentorship. And then overall, the big problems, the health systems, and I put in here the physician attachment. Part of that work is who's the most responsible physician, and there's a lot of conversations around that. Should it be a family doctor? Are the youth, are they too complex to be cared for by a family doctor? Then should it be the adult subspecialist? So Physician attachment really key to making sure that they have someone to go to, that they like to go to that person, and they actually attach. And what we talk about is a minimum of 2 visits. Referral network we're engaging on is actually a professional referral network that could possibly stand alone, so that we know who to refer to that may specialize in a certain patient population, a certain disease or a certain condition, that are very youth-friendly. Organization of care, that's local, regional, and provincial. You can see these are big pieces we're biting off here. Physician education and support, and structural change. And one of the projects, the Shared Care from BCMA, is looking at actually the changing of fee codes, so that if a family physician wants to take on a youth with more complex needs, will actually get paid for the hours that are required. Like I said real quick, was probably foundational to what we're doing is our evaluation. And it's from the moment we started. We looked at literature. We reviewed 40 programs of transition programs or clinics that exist. We did a provincial stakeholder workshop, which encouraged a lot of family docs to be there. And then we've done a youth workshop and a family parent workshop that was just held in the spring to really get the parent's voice of how to direct it. We also had baseline interviews of all the providers. So how do you actually provide care now? What do you do around transition? And then we did an internal document review. And we currently just did a family physician attachment study. Most subspecialists said, oh, no one has a family doctor and you can't find them. That may be true across all the provinces. When we did the study, actually 90% of the youth and families could identify that they did have a family doctor and they had been to see him or her at least once in the last year. As we're developing all of the processes and the tools, we've been using this technique, Plan, Do, Study, Act. I'm not sure if other people are doing it, but it's pretty common. So that you don't sit around a table and develop something, you actually take a small piece of something and you actually work at it and go out and test it in small little snippets. And that's what we've been doing, as well as case reviews. And if anybody's interested, I can go into detail with this and all of our data collection. I think the other thing that's unique is we're doing online surveys. Everything we're trying to develop, we're trying to get ongoing feedback from the stakeholders, and we'll be able to share that with others as well. So this is a quick slide that just shows the complexity of, some of our patients when they actually leave, because we all wear a different hat, whether we're nursing physicians or program developers or whatever we are, or parents, and we have a bit of a different lens, but it's important to take a look at this. This is, for example, if you have a spina bifida, you may be coming to a children's center and seeing all of your team there, your nurse, your physiatrist, your orthopedic docs, whoever that might be. When you go out into the community, it's all separate referrals that need to be made. It's all separate doctors that need to be seen to kind of do that surveillance to keep you healthy. A lot of them are different, right? They may not have a nurse. They won't have a social worker attached. So we're really used to, in these big pediatric centers, to have all of that support. And then when we go out into the community, it's not there. So this is just a model to show, some of the complexity of transferring out. The other big thing is what we're finding when we talk to more and more groups, rare diseases, or they're used to coming to Children's Hospital because they had a unique surgery. There's no one in the adult world that understands that surgery and will take them. So we actually do, and we look at the numbers, have a number of adults up to the age of 50 coming back to this center to get care or get information on how to take care of themselves. And then that's just the medical complexity. Then we look at youth that have more complex needs. We know there's a whole gambit of all the things that change, the schooling, the housing, the home care support, the day-to-day support in the house, all of these ongoing issues that are huge for the families to face on transfer. So if we can start ahead. So I put these forward because we're really interested if there's other people in doing transition that are interested in complexity. And Lisa had said we maybe connecting a little bit with the community of practice that's looking at complexity, because they do overlap a lot. This is just a triage scale that we're looking, we wanted to somehow quantify and be able to estimate the number of kids that are coming up through the system that need this additional help. And we just looked at cognitive abilities and ability to, family support, financial concerns. And it would give them a numeric number of subspecialties if they lived outside the Lower Mainland. We can tell that these kids need extra help, and right now we don't have services to support them. So quickly, if we look at, this is just like an algorithm of some of the tools and the processes we're developing. So we've got, I told you we're focusing on youth 12 to 24 years of age. We are currently right now just finishing up a transition clinical pathway for youth 12 to 18, and then there's been a lot of interest from the groups that we've been working with in the adult centers to say, hey, let's develop one for 19 to 24-year-olds that we can use once they transfer over. We want to, around this age of 14, start teaching them some skills and knowledge, and I'm going to share with you some of the stuff we're doing there. This is where the triage scale would come in, so we can early identify the kids that need the extra help. We are studying a readiness checklist for youth so that youth and the parents can self-identify, are they ready to go? And then on completion, they transfer with a full transition clinical pathway and a medical transfer summary. And that's a very comprehensive letter, but we've actually skinnied down the amount of, we just found that there was a huge discrepancy of what kind of information was being sent over to the adult world. The family docs in many cases weren't even getting that transfer information. And so there, again, the information was all staying at Children's Hospital and very little was moving on to the adult center. So we're working with adult teams as well to say, what specifically do you need in this medical transfer summary, as well as what do the kids need to be prepared for to come over to see us. Our measure of attachment, I think I said, was 2 visits into the adult care specialist program as well as to the family doc. And I think the big thing that we're looking at, learning about this time, is the completion of the skills and knowledge just isn't there at 18. And if we all think about either ourselves or our own kids, we are just not adults at 19. So how can we continue on that learning process into the adult setting? And I have to say, super receptive from the adult world to say, yeah, let's work at this together, and from family docs. They're saying, just tell us what they need, and we'll support it. So we have the pathway that's initiated at 12. As part of the pathway, making sure that they're confirmed with the family doc by 14, and that they've identified a subspecialist by 16, 17 years of age. I talked about the readiness checklist, the medical transfer summary. What's important about that is it's all the medical. What's the history? What do you need to know? But it's also anticipatory guidance, meaning within a year you should have this test done. You should be concerned if you have these kinds of symptoms. You should go and see somebody else because of that. And this is what's really unique, and we're pushing the boundaries, is a copy of this medical transfer summary and the transition pathway goes to the adult specialist.
There are 9 other callers on the call.
Hi. That goes to the family physician.
Hello, whoever's just calling, can you mute your line?
Hi, can you mute your line? Okay, I hope you're still there, whoever came on, and you can still hear. So what's unique is we're sending a copy to the adult specialist, the family physician, and the youth or family. And it's really pushing some buttons. But actually, the initial is shock, no. And then there's some interest and understanding. So we're still working through what would be shared, and I'm sure a lot of you are having thoughts right now, oh no, that can't happen. So we're going through those discussions, but we do know that the youth and our family really need to have that information on transfer, because some of our kids you know, we have the numbers coming at us around 50% do not make that initial attachment, and then they're lost looking for that transfer information. And then the long-term care plans is a really neat project. It is actually putting pediatric subspecialists at the table with adult subspecialists and saying, what's the best care that we should be providing? Because there's such a difference between pediatric and adult care often, that the families feel sometimes they're not getting the right care. So we're trying to create a standard by just putting docs together at the table and planning out what that should look like. And I'm going to be really quick and finish up. So really quickly, this is what the transition pathway starts to look like. The face sheet is a transfer sheet. This is all about who the youth is. These are reports that are attached that the team feels that are important to get copies to the adult provider and to the family physicians, and they're checked right off and making sure that they got those reports. There was a huge discrepancy on what goes to where, and again, these lists can be made condition specific. These are standardized templates. This is the inside of the transition clinical pathway specifically for a youth with a complex needs, and it may be that they just have, like I showed you that list of things, it may be that they have a number of, they may be special needs, they may have a number of other issues going on with them, and it just breaks down into what are some of the tasks that the youth and or the family should be thinking of, and then it breaks it down into a timeline. This is taking the pathway then. These are the items out of the pathway. This is off the simple pathway. We have two pathways, one for simple and one complex. Then we align it with a question that is youth-friendly, and that's where we come into the youth readiness questionnaire. And then what we've developed is a youth toolkit so that we can make up basically tips and activities and materials for if the youth can't do this, can I ask questions to care providers on my own? Well, if they want to, but they're not capable of doing that, how can they learn the skill to do that? And we can help them with that skill building. This whole toolkit system and the readiness is all going to be online so people can share. This is just one project that we have been working on. It's called TRAC It. This is our Youth Advisory Council. 90% of kids have access to phones. So when we talk about how do we engage youth in their care, it's through the phone. That's what we're finding. We have, with the kids, they've basically developed a model of how to use their phones. Now, this doesn't require an app or anything. It's just using the apps on your phone, notes, calendar, and contact page. And how would they use that to teach other kids to embed their medications, test appointment reminders, questions they have for the docs next time they see them. They've learned how to take photos of their lab reports or any information they want. And actually, we've won the opportunity to go to CAFC conference in the fall in the Puff the Dragon contest, and they're going to be presenting it. So that's it. And you can see that this TRAC It, this learning how to do these skills fits right back into the readiness and what we're looking at helping them do before they leave. And so I think, you know, overall the biggest thing that we've been doing is engagement face-to-face, and that's, you know, very respectfully listening to our stakeholders, which are our youth, our families, and all of our care providers, peds, adult, and community. Our partnerships have been really significant in helping us move forward. And spread is provincial. So whatever we do, we're trying to make it provincial, but I think a lot of this is national. You can use it anywhere. And then I talked about the toolkits, and they'll all be online. And our other outreaches are workshops for sure, and our ongoing newsletter. That's it.
That's great. Thanks, Mary.
So I don't know if we have time for questions, or people can contact me. Oh, can I plug in my email right now? If people want to contact me just after this with your questions or anything, you can do that. There you go.
Hi, Mary. It's Chris speaking. I have a question for you. I know we've been talking about this, but I wonder if the larger audience would be interested. You're sort of telling us that this is kind of in process, under development. The big picture to really be sharing this information across the country, even though it's BC specific in many ways, although it really isn't, right? What's your thoughts on that, and what can people kind of be looking forward to?
Yeah, well, we're hoping to launch our website in early October. So basically, we've built the youth toolkit. So we have a toolkit for each stakeholder group, and so the youth one will be launched in October. So all the readiness, all of the tips and tools, and like for instance, one of the tips is if you want to, learn how to talk to your doc, we actually link them to you guys at Sick Kids and say, hey, use your 3-sentence summary. So it's a way to we're just trying to pull another way to offer people the opportunity to, learn about what's already out there, because you don't want to duplicate the wheel. So I think that once we start posting everything, there'll be a lot of opportunities for collaboration, and I do think a lot of it will be useful across the provinces. And the strategies, I think we talked on the last call about the ministry protocols for transition, and I know Alberta's done one, BC, and I think now Ontario. Mm-hmm. So it's evident that it's happening throughout healthcare or throughout different ministries where you share, what are you doing, what worked within your, all of our provinces are where we have these kids that come out of a center and then they have to go into cross-regional, cross-jurisdiction care. They leave a pediatric center and then they go out. So I think a lot of us are in similar boats.
Great, thank you.
Does anybody else have any?
Else?
Hi, this is Joanne. Can you hear me?
Yeah.
Hi, yep. Hi, this is Joanne. Can you hear me? I have a question about the medical transfer summary. Just whether or not you have a format that you provide to the physicians or whoever who's doing that, creating the summary, and how you are getting others to use the same format.
Yeah, change. So that's the biggest part of because it's not like kids come to us. We are trying to embed these practices within not only our own organization, but going outside to other clinics. So what are we doing right now? So that in developing the medical transfer summary, we went out to we basically kind of started in-house, then we took it to adult practitioners. We took it through case studies to family doctors in the community. We also went through the literature extensively to say what are the legal requirements of a letter of transfer. And then, like I said, we had done the document review. That all gave us a lot of good, evidence to go forward. So at this point, basically, it goes into a transcription template because we don't have electronic records yet. But once we do, it will go into that. Then they'll be given a card and basically a cheat sheet to the areas that they need to transcribe or they need to dictate into the template. And already we've had a couple of teams look at it and modify it to be condition specific. So they're happy with the layout. The family docs were really happy with it too because they were getting really good information that they before were not getting. So we're at this point of these Plan, Do, Study, Act sessions around process and integration and uptake. We have at this point through a survey very positive verbal uptake that they'll do it. We haven't gotten to the point of actuality.
Would you be willing to share your template?
Yeah, absolutely. I think once we get this rolling and we fine-tune it a little bit, then I think our whole team is big proponents on sharing.
Thank you.